Up with the room. This is Grandrounds. Do we have one later in the month? Where's Ashley? Do we have one? Do you know? Does anybody know whether we have one, or is this the last one for 27? We're done? So this is the last Grandrounds for 2017, and it's just so exciting that we're capping off the year with a talk about something that we see every day, and that's I think there are a lot of opportunities for improving our processes. It's really thrilled to introduce Dr. Davis. Joined us a couple of years ago as one of our teaching physicians. Mike is a graduate of the college with the largest landmass in the United States, which is, anybody? Berry College, that's right, that's on their billboards in North Georgia. And then went to ETSU for medical school, actually rotated with us. And surprisingly still came back. Did his residency at UAB, did a fellowship in infectious disease at ETSU, joined us three years ago as a combined infectious disease and internal medicine teacher and faculty member. Must have been hit on his head because he then decided he wanted to be full-time involved with the teaching program and you guys, but joins us. He's also the director of the Center for Global and Community Health in the University of Tennessee, and is leading some exciting programs in that regard. And so I'm just thrilled to listen to Mike today talk to us about sepsis and all things like that. Thanks.
Thank you, Dr. Lambiase. I think before we get started, we should have just a pause for a moment and remember what 8 o'clock was like in 1941. This was the beginning, the Japanese surprise attack on Pearl Harbor, the beginning of the U.S. engagement in World War II. I have a patient in clinic who was there and once spent an hour talking to him to hear his story, much to the chagrin of my clinic staff, but if you have a chance to hear a story like that one, you should. It was a shocking moment and a unifying moment in American history. I just wanted to take a minute to recognize that. So we remember 76 years ago. And here are my disclosures. I have no financial conflicts of interest, but here's another disclosure. I think sepsis is fun because you get to argue about it. And we get to argue about it from the level of subcellular signaling molecules all the way up to which bundled therapies you should use and how you should use them. Part of that is built on what I'm going to argue is a mystery of some mechanisms. Pathobiology of individual patient responses in response to serious infection are something we wish we understood better than we do. I'll get into it a little bit. But I want to credit this brilliant author for the subtitle for this talk, J.R.R. Tolkien. I'm going to try to use his storytelling technique to illustrate the progression of sepsis diagnosis and management, especially over the past 20 years, and the process of starting with implementation science, when we started using the Rivers algorithm, and then trying to go back into basic science. So we went there, and then we went back again, then we went on with implementation science, and that's where we are today. There and back again. So here's the outline for the discussion. Like every story, there's a backstory, and I will limit myself to less than 15 minutes on the evolution of our understanding of the disease. These are the elements of the story. There's a setting, then there's a problem, and I'll use the case illustrations, some definitions, and some arguments from literature to develop the problem. The climax of the story will be illustrated through some interventions in bundles and the application of those interventions into Erlanger-specific data and some resolution and the call to action, how to go forward around QI interventions and some sepsis steering committee interventions, and we'll get to there. So sepsis discussion is as old as Hippocrates himself, and this is the Greek. And I love infectious disease doctors because they write articles about this kind of stuff. But the word means, sepsia means putrefaction, or the way flesh rots, or foul airs. It's a fair bit removed from how we understand the disease now, but if you get a chance to quote Hippocrates in your Grandrounds, you always do so. The next person that we'll talk about, likewise, Osler. Something that when he has something to add to your discussion, you always include him as well. And when you have a picture of his great mustache, then you include it in your slides as well. So he was really onto something in 1904 when he wrote this in The Evolution of Modern Medicine, that except on few occasions the patient appears to die from the body's response to infection rather than from it. And this is a key understanding in the truth that the patients don't die from bacterial overgrowth. They die from inflammatory response and the dysregulated host immune response. We'll talk about that more in a little bit, but we're going to have to skip ahead 100 years to the SIRS hypothesis and the inflammatory cascade understanding of sepsis. First really became popular around 1992. There was a consensus statement. We really started to think we were getting a good grasp on cytokines. And that's when the inflammatory hypothesis became eminently familiar, because we could have measurable physical manifestations in response to infection. These became very familiar. SIRS criteria: fever, tachycardia, tachypnea, leukocytosis, or immature cells. And there was a pathophysiologic progression defined as SIRS to sepsis to severe sepsis, septic shock, multi-organ dysfunction. And these fancy, super awesome Venn diagrams demonstrated some of the uncomplicated infection and the overlap syndromes associated with systemic inflammatory response. If you're a medical student and you can't think of an answer, always go with trauma and burns. Free information for you. But this led in 2001 to this seminal diagram flowchart management for sepsis and septic shock, and it was published by Rivers in the New England Journal. This is pretty familiar stuff as well. You're going ABCs, then catheterization for central venous and arterial, intubation, sedation if needed, and then measurement of your central venous pressure. This is a very familiar goal-directed therapy algorithm. CVPs 8 to 12, MAPS is 65, vasoactive agents, mixed venous oxygen saturation, goals achieved, and then supposedly hospital admission. This was the 6-hour goal-directed therapy intervention that was designed and tested on how many patients? 263 patients, and it changed the world. This was the mortality difference in inpatient, in-hospital mortality between the standard therapy group and the early goal-directed therapy group. In-hospital mortality for sepsis up to the start of the 21st century was consistently around 50%, 45–50%. This was a first major impact on in-hospital mortality, and those of you who were practicing in that time, this was a huge change in the way that we took care of patients with sepsis. 16% mortality reduction. That takes us to now. Following that major contribution in 2001, several iterations of the sepsis guidelines have come and gone. Bundled therapy has become a key part of our treatment, and the focus of the rest of this talk is on implementation primarily. Using these case definitions that were refined in 2016, and the Surviving Sepsis Campaign Guidelines published in 2017. I'm going to talk and make an argument for bundled implementation around 3-hour and 6-hour sepsis and septic shock bundles, and these are managed primarily by this Institute for Healthcare Improvement. That's where we're going to go for the rest of this discussion. But I chose to call this talk There and Back Again because I think this is an area of medicine in which the understanding of the basic science has been far outstripped by the understanding of implementation, by the push toward implementation science. And what is happening at the subcellular signaling level in an individual patient is an ongoing mystery that we're feverishly working to understand. Meanwhile, we're enrolling patients in millions of patients in implemented bundled therapy research. It's kind of a fascinating dichotomy of science and medicine. And we're trying to walk you through some of the most up-to-date understanding. This was published in the New England Journal in 2013. Another New England Journal of Medicine cartoon. Okay, try to focus in with me on this, this host pathogen interaction, and I will try to take you towards something that's clinically applicable today. Okay, promise. So what we were going after up from 92 to about 2010 was this pro-inflammatory response in response to pathogen factors, including the load or the number of bacteria, the virulence, and some pathogen-associated molecular patterns. There was an increase in these CLRs and TLR inflammatory mediators, also dependent on the host factors, which included environment, genetics, age, other illnesses, and medications. This led to leukocyte activation, cytokine and protease release, complement activation, and the perpetuation of an inflammation cycle, coagulation, and necrotic cell death. This was our primary focus up until about 2010, 2011. Then we started to really focus also on this anti-inflammatory response and using these signals to the brain through the hypothalamic pituitary adrenal axis. There was a release of catecholamines and cortisol, which inhibits some of this pro-inflammatory cytokine production, but also leaves you with some degree of immunosuppression and enhanced susceptibility to secondary infections. So this is what we understand as sort of the state-of-the-art description of pathobiology. How this ends up causing end-organ damage and hypoperfusion has to do with increased coagulation, mediated primarily through tissue factor, which is released at the level of necrotic cell death, as well as these decreased anticoagulation properties mediated, we think, primarily by protein C and activated protein C, and a decrease in activated protein C. Anybody remember our previous focus on activated protein C? Yes. That's why we have to be careful about cartoons, okay? This leads to decreased fibrinolysis and thrombosis, tissue hypoperfusion, mitochondrial dysfunction, and organ failure. I'm going to focus primarily on those things. So with a 5-minute diversion into subcellular signaling molecules in sepsis, I wanted to also add a couple of caveats. This understanding was built on animal models and on cytokine studies in healthy volunteers. And that, as clinicians, should make you ask a question: how many animals are you treating for sepsis? And also, how many healthy volunteers are you treating for sepsis? Especially if you go back to the anti-inflammatory response, if you can think of 5 to 10 factors in each patient that you're seeing with sepsis or septic shock that could affect especially these adrenal catecholamine cortisol response, beta blockers, steroids, other forms of immunosuppression. There's an awful lot of individualized response in the way the patients respond to this systemic inflammation. So would be, I think, a reasonable question then for us to include in our discussion. What we see clinically follows often this familiar end-organ involvement in systemic infection and inflammation. So often we'll see first some altered consciousness and confusion, followed by some cardiovascular compensatory mechanisms, tachycardia, and the blood pressure response tends to be early. Tachypnea and metabolic acidosis, including increasing lactate, which we'll come back to in just a few minutes, tend to be next, followed by oliguria, decreased renal function. By the time we're at the point of increasing liver enzymes and hematologic abnormalities, you're pretty far down the clinical spectrum of disease. Most of the time on healthy patients. This was the definition that was rewired in February of 2016, that sepsis should be defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Try and put that in your mind, and then we're going to take this into an actual patient case and see how we can use it. Sepsis should be defined as life-threatening organ dysfunction caused by dysregulated host response to infection. And here's a case, all right? We're going to use this case to walk through diagnosis and treatment. I know there are people named Merry Christmas. This is a fictional character that I made up, okay? Here's her chief complaint. She's a 76-year-old woman with fever, burning urination, and sick. She has a past medical history of dementia, coronary disease, atrial fibrillation, and CHF with an ejection fraction of 35%, last measured in 2016. She has some chronic kidney disease. Her baseline creatinine is 1.7. She comes to the hospital with 3 days, worsening fever, dysuria, acute on chronic confusion. Real life, okay? These are her vital signs. She's febrile, tachycardic, borderline blood pressure, a little low, respiratory rate of 23, oxygen sat of 94%. She's ill-appearing. Her GCS is 13 based on disoriented conversation and opening eyes to verbal commands. She's irregularly irregular, tachycardic without edema. Her chest is clear, her abdomen is soft. She's tender palpation around the right costovertebral angle. You guys are all over this one so far, I can tell. You know what's happening. Here are her first labs. Her white count is elevated at 24.8. It's 11% bands. Her creatinine is 2.3, and her white urine WBCs are 80. You guys are following? The rest of these labs? Okay. So, does Mary have sepsis? So this is a comparison table published from that same article, that same edition of JAMA, looking at assessment for clinical criteria. Fascinating article. I recommend that you read it. In the case I presented to you, I intentionally presented some data that would qualify her to meet sepsis criteria on any of these 4 measurements, okay? The question that remains for her, though, is that if she has end organ dysfunction that has a baseline abnormality, how does that impact her risk for systemic infection and response? And just to quote my friends from the Infectious Disease Society of America, who did not endorse the Surviving Sepsis Campaign guidelines, they report that their major concern with the guidelines is its failure to acknowledge practical difficulties clinicians often face when trying to diagnose sepsis. It is often unclear whether or not infection is present and whether or not organ dysfunction is due to infection. That's what the IDSA guys say. So, for Mary, among encounters with suspected infection, this is from this article, among patients with suspected infection outside of the intensive care unit, the predictive validity for in-hospital mortality of QSOFA was statistically greater than SOFA and SIRS, supporting its use as a prompt to consider sepsis. So we're going to go down this pathway based on that article. And I'm going to make a small argument against SIRS because this is a question that came up to me clinically as a practicing clinician. So my question was, how often, what's the incidence that patients would have 2 or more SIRS criteria over the course of a hospital admission? And these guys published this paper from the American Journal of Respiratory and Critical Care Medicine in 2015, and 47% was the answer. Hospitalized inpatients, 47% of this large series of 269,000 patients in 5 hospitals met 2 or more SIRS criteria at least once during their ward stay. That's a lot of patients. So what their argument in the discussion was that the SIRS criteria are too nonspecific to use as initial screening tools for ward patients. And I can suspect that you can think of 3 or 4 patients on your service right now who would meet 2 or more SIRS criteria that have no evidence of infection. So that's kind of what led to this development. In the setting of suspected infection, tachypnea, which QSOFA defines as 22, mentation, which QSOFA defines as anything less than 15, altered mentation, and systolic pressure less than 100 in the setting of acute infection. These are her data. She's respiratory rate of 23, her GCS is 13, and her systolic blood pressure is 94. A score of 2 or greater on this quick management, no labs involved strategy puts your risk of death for sepsis in the inpatient setting at 10%. And that was the cutoff that they used. So we've decided to diagnose her with sepsis. Now, what should we do? Should we just do whatever comes to mind? That's fairly common, okay? I'm going to try to make an argument for bundled therapy at this point, and I'm going to use primarily these 2 large multi-center trials. The first one is up here, the 7.5-year study of hospital mortality across low and high compliance sites for resuscitation management bundles. So this is a 7.5-year study. So this is, to my knowledge, the longest study of bundled therapy that exists in the literature, and it is 29,000 subjects that were from 2005 to 2012. And what was the definition of compliance? What was the definition of high compliance areas? Greater than 15%. So at the institutional level, if you were able to apply bundled therapy for sepsis at greater than 15%, then you are put into the high resuscitation compliance group. And if you look at the results from this table, the hospital mortality for a low resuscitation group was 38.6%, high resuscitation group 29%, highly statistically significant. The relative risk reduction in implementing those bundles was 25%. Relative risk reduction in death and in hospital mortality at the institution level. Well, I don't treat institutions, I treat individual patients. And so I want to know, well, what is the outcomes from an individual patient using the current metrics of 3 and 6 hour bundled therapy, which we'll get into in some detail in a moment. The IMPRESS study, published in 15 in Intensive Care Medicine, looked at, I've lost track of my things, 124,000 patients in 62 countries, and compared at the individual patient level the relative risk of death, people who were using and not using the bundled elements of therapy. And at the 3 hour bundled therapy had a 40% relative risk reduction in mortality compared to usual care. And we'll talk a little bit more about what usual care has become over the last 10 years. But the 6 hour relative risk reduction in mortality had a mortality benefit, relative risk reduction of 36%. These are pretty significant numbers. And I think it also is one of those moving targets in implementation science, because this was based on early goal-directed therapy, and some of the elements of which have since been proven to not have mortality benefits over what is now defined as usual care. So just the fact that we built a process that clearly has guidelines and timelines based on our best understanding of what's going on at the subcellular level gives us a chance to know, to really impact mortality. That's my primary argument. I hope you follow it. So what we should do next then is measure her lactate. Her initial lactate was 7. And we're going to go through the next few slides. I'm going to give you a pattern. These gray bars are going to be from these Surviving Sepsis Campaign guidelines published in March of 17. The part underneath it, which are these numerals 1 to 4, are going to be from these resuscitation bundles. Okay? So an argument for lactate measurement. So serum lactate is not a direct measure of tissue perfusion. However, and it can be increased in non-sepsis-mediated pathways, including tissue hypoxia from occlusion, accelerated glycolysis from excess beta adrenergic stimulation or vasospasm, and other causes including liver failure. However, any increased lactate is also associated with an increase in mortality. So with hyperlactatemia alone in the setting of sepsis, at a lactate greater than 2, your mortality was reaching to 25%, greater than 4 at 29%. So you're starting to have the slope of your line clearly defined by the evidence of end-organ perfusion. Will we develop better markers in the future? Maybe. But this is what we've got for right now. And here's an argument for lactate clearance, or serial lactate. This is a meta-analysis published in Intensive Care Medicine in 2015, which compared early lactate clearance-guided therapy in patients with sepsis in these randomized controlled trials versus usual care. So this is what happens in usual care, and I do this myself. You'll get an initial lactate which is elevated, you'll bolus people, and then their blood pressure will come up and you'll never think about it again. That's kind of the usual care method, and that's what we often do. So when I was told that we needed to do lactate serially, I thought, well, why? If they're clinically better, I don't see a benefit from it. If you look at this trial, though, the relative risk reduction in mortality was around 33%. So these are about 67.67 on this forest plot. It's a pretty 0.65. So a pretty good argument in my mind for measuring that second lactate. I think there's probably some more sensitivity in serial lactate than there is in just the clinical reassessment strategy that we've used historically. And that's why there's lactate number 1 and lactate number 2 in sepsis bundle therapy. So what's the next thing we should do for Mary? We should give her fluids. Okay, so here's from the Surviving Sepsis Guidelines. Medical emergencies recommend treatment resuscitation begin immediately. This is their best practice statement. We recommend that resuscitation for sepsis-induced hypoperfusion at least 30 cc's per kg of IV crystalloid within the first 3 hours. Strong recommendation, low quality evidence. We recommend that following fluid resuscitation, additional fluids be guided by frequent reassessment. And then how they applied this in this 3-hour resuscitation bundle was administering crystalloid for hypotension or lactate greater than or equal to 4. Slight differences in the implementation and slight differences in the understanding of what's underlying this initial response to fluids. So how did we get to 30 cc's per kg? It's interesting. It was just the chosen strategy in the initial resuscitation trials. If you do 30 cc's per kg and someone is 70 kilos, like the imaginary 70-kilogram man, it comes into just over 2 liters of fluid, which is also the rough volume of fluid that was administered in all of these early goal-directed therapy trials. The process study, all of these are fluids in the first 6 hours in the early goal-directed trials. Volume of fluid is in black, standard deviation of all of these except promise. And these are the mortality bars. So after this big Rivers paper in 2001, which showed this relative risk reduction in mortality, the control and the early goal-directed therapy trials all sort of hovered around this 2 liter or so volume administration. And in the process in the ARISE trial, approximately 2 liters were given prior to randomization as well. But this is total volume. So that's, and then the other question, which is an intriguing one, is you give these initial fluids, how fast do you give them? This is an observational study around 2,000 patients and showed an association and mortality benefit of administering fluids in less than 30 minutes of severe sepsis identification, and compared it with hospital mortality and length of stay. So patients who had fluids within 30 minutes had a 5% lower mortality and 1 day shorter median length of stay versus those who received ejection fraction in her H&P, which I gave you, which is a little bit more than we often will get. in true clinical practice. And so this is the only data I could find on what happens to people who get 30 cc's per kg of IV bolus fluids who have a history of CHF or are on end-stage renal disease. And so of these patients, that was a single center trial out of Phoenix, Arizona, the intubation rate and mortality rate and the hospital length of stay were not statistically significant between those who received 30 cc's per kg of IV fluids and those who did not. So the take-home message from this is that in patients, even with diagnosed heart failure and end-stage renal disease, they're not more likely to be intubated. They don't have a statistically significant difference in the risk of mortality if you give them the fluids, which is a challenge to our clinical practice, and I leave it with you. The next step upon the pathway, we've gone lactate measurement, we've given fluids. Next step along the wet pathway is obtaining culture specimens. So from the Society of Critical Care guys, recommend routine microbiologic cultures, including blood, obtained before starting antimicrobial therapy. And then the severe sepsis 3-hour resuscitation bundle, folks, obtain blood cultures prior to antibiotics. They suggest in the text of the guideline that 45 minutes is an example of what may be considered no substantial delay between presentation to the hospital and the obtaining of blood cultures. And that's tied to a target of administering antibiotics, which we're going to get to in just a minute, in less than 1 hour. You give a first dose of Zosyn for someone who's gram-negative bacteremic, their blood cultures are going to be cleared within minutes to hours. So you have a much higher chance of getting a microbiologic diagnosis if you obtain your culture specimen prior to the administration of antibiotics. This leads to early de-escalation, making antibiotic stewardship committees happy, and better patient outcomes related to toxicities and the driving of drug resistance. Okay. Now on to antibiotics, and this is where it gets a little contentious. Antibiotic therapy as recommended by the Society of Critical Care folks. There's too much to look at here, but in general, you want them as early as possible. Goal would be 1 hour. Empiric broad spectrum therapy for all expected pathogens, and they even include some bacterial, fungal, or viral. Empiric antibiotic therapy gets narrowed once an adequate clinical improvement or you have a pathogen identified. There's a little bit of, we're just going to skip over here about antibiotic prophylaxis and pancreatitis and burn injury, but the dosing strategies of antimicrobials should be based on what you understand about their pharmacokinetic, pharmacodynamic principles. And they suggest empiric combination therapy, which is 2 antibiotics from different classes targeted at a single bacterial species. And that is an arguable piece of recommendation. And they recommend continuing that, not continuing that for most other serious infections, including bacteremia and sepsis without septic shock. So they kind of go back on the other side of the combination therapy discussion. And so there's some uncertainty in that recommendation, and I think there's a reason for it, and I'll come back to it in just a minute. But you need to give antibiotics. You need to give antibiotics in a broad spectrum manner. You need to give them quickly. If you look at this study in the emergency department, in a retrospective analysis, the odds ratio for mortality for each comparing patients within each hourly antibiotic administration group with a reference group shows that there was a 9% increase in mortality for every hour after hour 1 for the administration of antibiotics. So we've got tight time frames that and they're getting tighter all the time. 30 minutes for fluids, 45 minutes for cultures, 1 hour for the first dose of antibiotics. And I have to give some reference to my colleagues in the Infectious Disease Society of America, and they published this paper in CID in November last month about why the IDSA did not endorse the Surviving Sepsis Campaign guidelines. And I think there were several sort of philosophic differences. Primarily, they wanted to differentiate between sepsis and septic shock in terms of the rapidity of broad-spectrum empiric antibiotic therapy and the relative risk of waiting and making a clinical diagnosis. And they also had some disagreement with this statement that an antimicrobial treatment duration 7 to 10 days is adequate for most serious infections. The IDSA is always going to want you to make an infectious disease clinical diagnosis before you choose antibiotics, and you should choose and tailor your antibiotic therapy based on that diagnosis. And this should give you a duration of therapy which in the recent literature is getting shorter and shorter and shorter at all times. 7 to 10 is going to be too much antibiotic and for too long. The duration of therapies and guidelines from randomized trials say that intra-abdominal infections, abscesses with source control can do 4 days of antibiotics. Community-acquired pneumonia, 5 days is often sufficient, and there are 7 days or less for nosocomial pneumonia, 7 days or less for acute pyelonephritis. That's the pointy-headed ID doctor's perspective, okay? We gave Mary ceftriaxone in less than 1 hour. Congratulations, guys. We did a good job. Okay, so this is it. We've followed her through her first 3 hours in the emergency department. We implemented a bundled 3-hour strategy for sepsis management. We've reduced her relative risk of mortality, if you look back at the IMPRESS trial, by 40%. Good job, guys. 4 things. We can do 4 things, okay? Despite our best efforts, she continues to deteriorate. We have to get to the rest of this talk, okay? So she's now 80/45. Her heart rate's 134. She's beating 30 times a minute. Oxygen sat's 93%. And you receive a call from our friends in the microbiology lab. Charlotte, her blood cultures are gram stain positive, 4 out of 4 gram negative rods, as we expect. Okay, now we're in the ICU, and the discriminant validity of the full-length SOFA score has been proven to show the risk of mortality more clearly than the quick measurements that we do prior to the ICU. And we can now implement, we can use this table to describe her relative risk of mortality. Some data I didn't give you because we didn't have it was her P to F ratio, and her platelets are 119. Her bilirubin is not known. She is now has a MAP less than 70, is on her way to being on norepinephrine. Her GCS is in this 13 to 14 range. Her creatinine is 2.3. And that gets us to vasopressors, all right? We recommend norepinephrine. This is the Society of Critical Care guidelines. Norepinephrine is the vasopressor of choice. Strong recommendation, moderate evidence. Then adding vasopressin or epi to norepinephrine with the intent of raising mean arterial pressure to target, or adding vasopressin to decrease norepinephrine dosage. Dopamine, the language around dopamine in the guidelines now are as a alternative pressor agent in highly selected patients. Recommend against low-dose dopamine, suggest using dobutamine only in people who have persistent hypoperfusion, despite adequate fluid and the use of vasopressors. This is a weak, low recommendation. In the new bundled therapy guidelines, after the vasopressor administration and persistent hypotension, to meet these requirements, you need a focused repeat exam within 6 hours, which includes vital signs, cardiopulmonary examination, capillary refill, pulse and skin, or any other 2 of the finding. Measure the CVP, measure the mixed venous oxygen saturation, do a bedside cardiac ultrasound, or try this dynamic assessment of fluid responses, passive leg wave, or leg raise, or fluid challenge. These are some of the new and, to be honest, difficult to prove measurements for tissue hypoperfusion and hemodynamic response in the modern era of sepsis therapy. So we've done it. Now, this is just another way of looking at the same thing. We're going to look at it another way in just a second, but this is the 3 and the 6 hour surviving sepsis campaign bundles. We measured lactate. We got blood cultures. We gave antibiotics for hypotension or lactate greater than 4. We gave volume. Then we applied vasopressors after the initial fluid resuscitation did not meet her mean arterial pressure goal. And in the event of persistent hypotension, we did these measurements and remeasured her lactate based on that argument from the lactate clearance strategy which I showed you earlier. So conclusions from Mary, great job. She responded to ceftriaxone and her other therapies, and she was day 2 off vasopressors, returned to her baseline level of functioning. I love stories with happy endings, all right? So here's another question. How would Mary do at Erlanger? I'm going to talk a little bit about Erlanger-specific data, but before I do, I want to do a few caveats because it's relevant to a broader discussion. The folks in JAMA published this in October, which looked at the incidence of billing for sepsis, which is how we get a lot of our incidence data now versus the incidence of sepsis in a electronic health record review using the most up-to-date guidelines. And what I found was that though everyone who starts a sepsis talk or starts a sepsis paper writes about how the incidence of sepsis is increasing, when in fact probably the incidence is pretty stable based on clinical criteria. The use of codes for sepsis is increasing, and that puts quite a bit of uncertainty in the epidemiologic results and some of the outcomes results from sepsis. So we're learning exactly what that means, but in order to be able to compare apples to apples, then you have to still use the apples even if they're kind of sour. Okay, so we're using claims data in order to follow our sepsis trends, which is the same way that they're being used across the United States and the world. However, keep that in the back of your mind with a grain of salt, because some things that are billed as sepsis are not going to actually be sepsis. But we'll use what we have, and this is what we have. This is a table of mortality data from the Tennessee Hospital Association up to December of last year, about 1 year ago. For the slide itself is kind of complex. I'm going to try to run you through it. For whatever reason, they put the mortality data in hundreds instead of true percentages. So in order to understand our mortality, you just move this decimal point over here. Now, the comparators to Erlanger Baroness are the Health Research and Education Trust Tennessee hospitals and the teaching hospitals. So those are the ones I'm going to kind of focus on. There's 64 hospitals in Tennessee that participate in this data sharing group, and then there are 49 hospitals throughout the United States. And if you look at this is our basal rate for hospital onset mortality in 2014. And the reason we use hospital onset mortality is because it gives you a clearer picture of people who of the individual performance of the hospital. It's pretty frequent that people will argue that, well, everyone sends their sick patients to Erlanger, and that may or may not be true, but what we're trying to differentiate here is this is sepsis that was not present on admission. Hospital onset mortality up to 2014 was 42.7% at Erlanger Baroness compared to these Tennessee hospitals, roughly 36, teaching hospitals like we are, 31%. And then this was pretty consistent, around 10 percentage point difference between month to month, October, November, December, with a variable here in November of 16. Overall sepsis mortality also pretty consistent at around the 10% higher inpatient mortality on average versus both the other Tennessee hospitals that participate in this group and other teaching hospitals. We have some room for improvement. And it can be improved. The guidelines do recommend that we have performance improvement programs, which we get to be a part of, including sepsis screening for acutely ill high-risk patients. There are a great number of papers on sepsis quality improvement, and there are lots of measures that have been shown to improve outcomes. Order sets, screening tools, physician prompts, and EHR pathways are some that we're going to talk about. Also, this code sepsis intervention strategy has been proven to improve mortality in patients with hospital onset sepsis. This will be coming in the future, and we'll be discussing it as it comes on. But what I want to focus on, though, is the EHR pathway in EPIC, and I will use that as a local call to action. Okay, I'm going to pause for 1 second to see if anyone has seizure from an epic screenshot. I wanted to have the videos from Dr. Page's seizure lecture, but anyway, so this is the current state of the best practice alert. There's evidence for systemic inflammation. They use these guys from SIRS, but an organ dysfunction, the patient may be septic. Do not assume that these are result of a condition already identified. If the patient has changed clinically, notify the code sepsis rapid response team and the provider and do these things. What do? We do blood cultures. We measure lactates. This is a best practice alert. And that gives you an opportunity to follow this pathway. And it's designed to make it so that we can apply this best implementation science as simply and easily as possible. The first thing that's going to pop up is going to be lab opportunities, blood cultures. Then, based on your clinical judgment, your analysis of sputum culture, lactic acid, either from arterial, venous, or ISTAT. I recommend ISTAT lactates if possible. And then, as needed for one occurrence, if the initial lactic acid is 2 to 3.9, then draw another in 6 hours. This is the repeat. This is the way to get yourself in that 6-hour bundle lactate clearance strategy. It's there. The other thing is to start administering your volume. That 30-minute target is hard to get to, but it can be done. This bolus dose is for over 1 hour or as fast as possible until hypotension resolved, or must infuse over 3 hours. These are some other fluid options, infusions for maintenance fluids after the initial therapy. This is my sad face slide for antibiotic therapy and medication administration. We argued about this a lot in the committee, but it's there. So antibiotics for community-acquired infection include rocephin and zithromycin, and if risk for MRSA, advancomycin. And then for healthcare-associated infections, their recommendation is cefepime, piperacillin, and tazobactam. There's also some insulin dosing options and some other parts that are also included in the Surviving Sepsis campaign guidelines from Society of Critical Care Medicine that I did not include in this talk just because of time. But this is what's available. These are the check boxes available to treat those underlying infections and get at least your first dose of antibiotics in. And how long? 1 hour if possible. Then there's option for vasopressors. Probably this should be on the top, and then this should be in the middle, and then this should be at the bottom. But it is what it is. We'll continue to work on some of these things, but you get your MAP goals, and that's the ubiquitous accept button. How many times do you hit that button in a day? Okay, this is the initial pathway to success in the bundled therapy components of sepsis care at Erlanger. I wanted to acknowledge this group of people, and I won't read everyone's name or all of their initials, but I just wanted you to get a sense of how many people and of what a broad array of disciplines it takes to take a system as big and complex as Erlanger Hospital and try to build a quality improvement process, and we really thank those who are in the audience as well. From multiple disciplines with lots of different perspectives. So I'm thankful to be a part of that group. And so here's the summary. We've got a little bit of time. We have gone there and back again on sepsis diagnosis and management. And it remains an interesting dilemma. When you see an individual patient like Mary who has baseline organ dysfunction, and you have to make diagnostic decisions based on variations in organ dysfunction related to systemic inflammation, and you have to make treatment decisions that take into account her underlying organ dysfunction. It gets very complicated, and that's why you need a clinician who is astute. And also made an argument that bundled therapy saves lives in sepsis. We can and should use them, and I think it will improve our local outcomes. Thank you.
Open it up to any questions. Does anybody have any questions?
Matt?
I don't know if you can hear me okay.
I can hear you, Matt.
All right, thanks. Thanks for the talk. Just some comments off of that. Very good. Going back historically, the Manny Rivers study prompted almost everybody with sepsis to get a central line. And that was sort of the dogma. Sepsis is a central line to get a CVO2, get all these various different variables to resuscitate, even an nitroprusside in that study to help with resuscitation. The recent bundle of studies coming out basically said you don't need to do that. You don't need to place central lines. You can just give fluid and resuscitate and use a clinical judgment is as good, if not in some cases maybe better with that.
Mhm.
So a central line, certainly if they don't respond to IV fluids and need a vasopressor, that would be your main reason for doing a central line with that. So that's going to change over probably the last 3 years or so.
Mhm.
Another thing that may or may not come down the pipeline, but is somewhat exciting, is that there's been some studies into high-dose vitamin C, low-dose hydrocortisone, and thiamine as a potential dramatic mortality benefit. Whether that's going to pan out or not in large randomized trials is yet to be seen. We're talking 30% absolute risk reduction, which is better than your bundles. So, and there's some pretty good science behind it. And the last thing is please don't put anybody on phenylephrine. If you have an septic shock, don't do that. Use norepinephrine as your first line agent.
Thank you, Dr. Abadar.
Yeah, I have a few comments. So sepsis, we have to keep in mind sepsis is not a hypovolemic shock. It's a vasodilatory shock. And there is a recent study published in JAMA which showed that the bundle that we use 30 ml per kg increased mortality. So there is a lot of papers in the literature which shows that early administration of so much like bolusing these people increases mortality. Every individual responds differently to the fluid. And about fluid assessment, passive lag raising test is like the most specific because it has the value of 0.85 of receiver operator curve. CVP is already debunked, nobody uses it assessment because it is altered by many factors. The other thing I want to make a point on, which is like a lot of research is going on Starling forces that we studied maintain intravascular volume. There is a revised Starling forces now. There is an element in the endothelium called glycolax layer, which is denuded by because of the boluses that we get. And that causes perfusion of proteins, inflammatory response syndrome, and increases mortality. So I think this 30 ml per kg is totally wrong. And the study they did in Africa, and a lot of people have HIV and tuberculosis, the mortality difference was 48% in these people who got 40 ml per kg, 36% who got this normal resuscitation. And early use of vasopressor with fluid resuscitation are better because these people are not hypovolemic at all. These are vasodilators. So we need to think about the physiology too in all these things. And the only thing that decreases mortality is early recognition, what you are like teaching. We need to find out which all people are septic and then act immediately on them and then take care of them.
Yeah, there's some evidence that almost all the studies out of Africa show mortality disadvantage in early volume.
Early resuscitation in the pediatric age group increases mortality at 48 hours.
So the take-homes don't get septic in Africa. Well, thank you very much.
Thank you, guys. Sir.
The elevated lactate, is that just a marker